Okay, respiratory diseases. So in this we'll talk about mostly COPD, chronic bronchitis, emphysema, asthma, pneumonia, pneumoconiosis, tuberculosis, and cystic fibrosis. So the term COPD, chronic obstructive pulmonary diseases, predominantly for our purposes we're going to address chronic bronchitis and emphysema, not asthma. Asthma's gone back and forth about whether it's COPD or it's not. We're going to take the approach that it's not, and I'll be able to defend why we don't appreciate it and address it that way. So about 14 million people or so with COPD. The majority have chronic bronchitis, and there's a reason for that we'll see in a little while. About 2 million or so have emphysema. So chronic bronchitis is defined in clinical terms, whereas emphysema is defined in terms of anatomical pathology. What that means is that patients' complaints, based on the complaint, you can diagnose chronic bronchitis, whereas a diagnosis of emphysema really requires somebody to do a scope, bronchoscopy, which people really don't want to do just for diagnostic purposes. So when people wake up with that smoker's cough persistently for multiple months without any other history, that's chronic bronchitis by definition, whereas emphysema, you need to see some things clinically under the microscope. So emphysema is defined as an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. Whereas chronic bronchitis is defined as the presence of a chronic productive cough for 3 months during each of 2 consecutive years, with other causes of cough being excluded, things like respiratory asthma or exertional asthma or sarcoid or something like that. So as you can see, chronic bronchitis is basically based on patients complaining of chronic cough. So it explains why there's dramatically higher amounts of chronic bronchitis versus emphysema. Okay, so when we take a look at these, we see that the increased amount of active polymorphonuclear leukocytes, read that as neutrophils, and macrophages, they release what's called elastases. Elastases are going to rip apart elastin. Elastin's part of the lung tissue, which is going to help to reconstrict the lung tissue. So if you picture the lung as a balloon, you blow up the balloon, and then the balloon has to contract to blow the air out. Well, that elastin is what helps to blow the air out. So if we have elastases, that means the particles that are going to help the lung blow air out are being destroyed. So that's going to result in permanent enlargement of those small air cells. Also, increased oxidative stress from free radicals and cigarette smoke. These oxidants released by phagocytes and the neutrophils can lead to apoptosis or necrosis. With chronic bronchitis, you get neutrophilia. The neutrophilic infiltrates, they accumulate in the submucosa. They can cause airflow limitation. They can narrow the airway walls. Emphysema has basically 3 patterns. Sorry, number 1 is centri-acinar emphysema, which is focalized destruction to the respiratory bronchioles, and that's the most common, associated with cigarette smoking. The second one involves the entire alveoli distal to the terminal bronchiole, and this develops in patients with something called alpha-1 antitrypsin deficiency, AAT deficiency. We'll talk about that a little bit later. And there's a third type, distal acinar emphysema, or paraseptal emphysema. It involves the more distal structures. Okay. So if we take a look at the role of inflammation, so in contrast to the eosinophil, which is the most prominent inflammatory cell of asthma, the cellular composition of the airway inflammation in COPD is predominantly mediated by neutrophils. Right? So you know that neutrophils, and remember, respond to inflammation, and they're really the definition of what inflammation is that you have neutrophils present, whereas eosinophils respond more to allergy, which is where we go with asthma being sort of a reactive airway disease, an RAD, not a chronically obstructing disease. Okay, so cigarette smoking induces these macrophages to release neutrophil, chemotatic factors, and elastases, thereby actually destroying lung tissue. Most patients with COPD have smoked for at least 20 cigarettes per day for 20 or more years before the onset of symptoms. Right, so we need to understand the concept of what's called a pack year. A pack year means 1 pack of cigarettes a day for 1 year. So if a patient can have 20 pack years by a lot of definitions. If they've smoked 1 pack a day for 20 years, that's 20 pack years. If they smoke 2 packs a day for 10 years, that's 2 times 10, that's 20 pack years. If they smoke half a pack a day for 40 years, that's 20 pack years. So that's really what we're looking for, is 20 cigarettes a day for 20 years, that's 20 pack years. So 4 packs a day for 5 years, that's the equivalent. So patients complain of a productive cough, usually worse in the mornings, that hacking smoker's cough, usually colorless sputum, breathlessness very late, and then there's some tests which we'll talk about under pulmonary for FEV1 and FVC. The physical exam doesn't really help you out too much. They usually have tachypnea, respiratory distress, dyspnea on exertion. Respiratory rate is going to increase proportionally to disease activity and disease severity. And you can see some respiratory muscle and paradoxical respiration. Again, we'll talk about a little bit later about forced expiratory time and forced vital capacity. What you might see with the thoracic exam, things like hyperinflation or barrel chest or increased A to P diameter. You might hear some wheezing, diffusely decreased breath sound, some hyperresonance, and some prolonged expiration. Coarse crackles and wheezes. Again, all that wheezes is not asthma. For the lab studies, you might see a polycythemia, as we discussed earlier, right? Decreased blood oxygenation would lead to increased red blood cell production from erythropoietin in the kidney, stimulating the bone marrow. You might do a test for alpha-1 antitrypsin, and you should be doing sputum cultures. And the sputum culture is going to help to figure out whether it's eosinophilic based or neutrophilic based. Obviously, smoking cessation continues to be the most important thing to do. And if you look at cor pulmonale is right ventricular failure caused by the respiratory system. Okay, so pulmonary hypertension is this common link. What happens is that in people with respiratory disease, the small parts of the airways go under bronchoconstriction, right? Because if you have a diseased lung, the body tries to say, okay, if this is a diseased lung, let's not send air there to try and have exchange carbon dioxide with oxygen. So we'll sort of shut down the air supply to that area, and you get bronchiectasis and atelectasis. Well, what happens is when you shut down the air supply there, you also usually shut down the blood supply. So you get pulmonary vasoconstriction. So now you have pulmonary vasoconstriction. That increases your peripheral vascular resistance, right? Increased vascular resistance in the lungs means that the blood vessel that pumps the blood into the lungs has to work harder. Well, we know that the blood vessel that pumps the blood into the lungs is the right ventricle. The right ventricle is not meant to pump hard. The right ventricle is meant to pump blood to its neighbors, the lungs, not to have to pump against gravity and do all this hard work like the left ventricle is. So the right ventricle will go into failure and dilate fairly early. Okay, and that's what's called cor pulmonale. So you get increased blood viscosity, increased blood flow, idiopathic pulmonary hypertension. Right, so you have this right ventricular thin-walled chamber. It's more of a volume pump. When you have an increase in afterload, that right ventricle has to increase pressure. Okay, and you're going to get right ventricular dilation and right ventricular circulatory collapse. Okay, so there's a term, cor pulmonale, which is right ventricular failure secondary to respiratory disease. Okay, so if you have a decrease in right ventricular output, that can decrease the left ventricular volume, which is going to decrease left ventricular output. Right, so the right coronary artery supplies the right ventricular free wall. Since it comes off the aorta, decreased left ventricular output diminishes pressure in the aorta and decreases right coronary blood flow. You then get this decreasing and descending cycle where, since the left ventricle is not pumping efficiently, then blood's not going into the aorta efficiently. Blood's not going into the aorta efficiently, then you're going to get decreased right coronary and left coronary blood flow, which, guess what, is going to decrease the ventricular performance. Right ventricular overload is associated with displacing the septum towards the left ventricle. If you shift over that septum into the left ventricle, that's going to decrease your stroke volume. Right? So that's about 10 minutes on COPD with chronic bronchitis and emphysema. Right? So it's remembering that chronic bronchitis is a large accumulation of neutrophils, of this cough, chronic cough on a regular basis. Right? And both of these diseases, really what you have, well, more with chronic bronchitis and emphysema. Bronchitis is sort of like trying to breathe through a straw, but if you fill up that straw with half of a milkshake, and now you're trying to inhale and exhale through a straw that has a whole bunch of mucus in it. Well, that's chronic bronchitis. Whereas emphysema, you really got to remember about trying to exhale, but not those small airways in the lungs not being able to constrict normally to shove air out. So you're getting accumulation of carbon dioxide sitting there in the lungs, not being exhaled, which is why you get that carbon dioxide increase. And you've heard amongst your patients where they're oxygen sensitive because their brains switch over from being sensitive to carbon dioxide. Well, if you have this constant high amount of carbon dioxide in your bloodstream, your brain and your medulla have to turn off that sensitivity to carbon dioxide, and they have to turn on their sensitivity to oxygen. Okay, that's underlying some of the patho of what's going on with COPD, and we'll come back in a few.